think we move on to discussion on diabetic live donors. Since we did not achieve a consensus on obese donors, let's try and see whether we reach a consensus on diabetic. And Dr. Santosh Varughese from CMC Vellore is the best person to talk on diabetic live donors, giving in 10 minutes what he feels we should do with a diabetic live donor.
Much so for the kind invitation, and I'm happy to be here. Regards to dignitaries on the dais and off the dais, the question for us when we talk about kidneys from diabetic donors naturally fall under two headings. Is it okay for recipients to receive? Is it okay for donors to donate? I'll deal with the least controversial one. Is it okay for recipients to receive? So the survival analysis of transplantation from the disease donor waiting list way back in 2017 showed that taking kidney from a diabetic donor was better than being on wait list or a non-diabetic donor in the overall cohort. But when you divide by different KDPIs, candidate willingness, as well as being patients who are active, patients of 2004 or later, at all points, diabetic donor was better, especially if the KDPI scores were reasonable. And they also found that overall in the US, centers with the longest median waitlist time, it made sense for them to accept diabetic donors, showing us conclusively that accepting kidneys was good for the recipient. They also, when they looked at the kidney biopsies for these patients at the time of transplantation in a cohort of 25 disease donor kidneys, post-perfusion biopsies, they found there was a very low amount of actually frank diabetic changes, making it, and we know that most of them can reverse after transplantation, making them good donors as far as the recipient is concerned. So having answered that question successfully, let's go on to the controversial topic, which is the meat of this discussion. Is it okay for our donors to donate? So first question is, look at occurrence of diabetes after kidney donation. The data shows from this study showed that, sorry, I need to go back. This study of 2005, 954 donors, about 154 patients developed diabetes 17 odd years after donation. The risk factors were high BMI, which we talked about in great detail, and male gender. And male gender and age of donation were about 40 years. The time for diagnosis of diabetes was about 58 years, which is important for us to remember. Our data from our center over 10 years showed that of 369 donors, 550 that we had good follow-up of glucose levels at last follow-up, 5% patients developed diabetes, but a large number had impaired glucose tolerance, fasting glucose, or both. The mean age of diagnosis was about 50 years, little less than a decade less earlier than the Western counterparts, probably in keeping with our life longevity, etc. The mean time for diagnosis post-donation was 2 years, but they also had higher median proteinuria. The pre-donation risk factors that we found were on universal analysis was fasting glucose, postprandial glucose, blood pressures, but more interestingly, the mean duration of follow-up, which was there even on the multivariate analysis. I'm sorry, it's not projecting very well. So fasting glucose, even as high as 101, actually portended risk factor for new onset diabetes. And the mean duration of follow-up being different also suggests that if we were to follow up these people longer, the risk, as in all of us, is higher for these patients. Looking at diabetes per se, the European Renal Best Practice Guidelines in 2015 said they recommend that diabetes is a contraindication for donation other than exceptional circumstances. In the KDIGO said the donation to approved donors for pre-diabetes or diabetes, they club the two together, should be individualized based on demographic and health profile in relation to transplant programs acceptable risk threshold, leaving the ball perfectly and only in our courts. The AST guideline says clearly that the UNO says that potential donors with diabetes be excluded from donation. 2018, the British Transplant Society and the Renal Association UK guidelines for donors came up with a statement saying that very careful evaluation of risks and benefits should be done for potential diabetic donors. Absence of target organ damages, cardiovascular risk factors like obesity, hypertension, dyslipidemia, and a thorough assessment of the lifetime risk in the presence of a single kidney, and again, not graded. Then there was the landmark statement last year, the OPTN statement, which was quoted, and I quote, unless assessment of donor demographics or comorbidities reveal either evidence of end organ damage or unacceptable lifetime risk of complications, meaning that diabetic donors could be accepted. However, that was actually not what the statement said. I looked at the verbatim statement. They said you must exclude all donors who meet any of these, and they have a whole list of criteria in the dysglycemia category. It is type 1 diabetics or type 2 with individual assessment has end organ damage or unacceptable lifetime risk of complications. It's not defined in the OPTN. There was a Perspective, very interesting article early this year talking about accepting living donors with pre-existing diabetes. It is based on the premise that, like the US, the rest of the world will do annual screening for diabetes at the age of 45, which we know that most of us, including myself, haven't done. What this paper suggested was the eligibility criteria be very stringent and exclude risk of a lifetime risk of end organ damage. They be non-insulin dependent, older than 55, maximum of 2 oral anti-diabetic medications, duration of at least 3 years. That means you've known them for having diabetes which is stable, no smoking, no diabetes, no hypertension, no obesity, normal end organ damage like fundus examination, no dyslipidemia, UCR or UPR being low, HbA1c less than 7%, meaning well-controlled diabetes. This is the recommendation. This isn't based on any data or studies. But before we have our discussion, which is what we're here for, let's look at what does the data say. The data is actually very, very scant, but what there is, I will present before the learned audience. The first paper was 2010 in transplantation from Japan. For some strange reason, all the papers that are there are from Japan, looking at live kidney donors with pre-existing glucose intolerance without diabetes or otherwise. And they had two groups, the glucose intolerant group, which had 27 diabetes and the rest had impaired glucose tolerance, versus 373 normals. And their paper was the first one to show that the survival was not impacted based on dysglycemia. And the important thing is there's a self-reported data. It was not a systematic follow-up, and they found that there was only 1 person who had proteinuria. Then in 2018, there came this paper which showed no differences in short-term renal prognosis between living donors with and without diabetes. They had 225 donors, which 14 were diabetic and 211 were not diabetic. Minimum follow-up of 4.3 years. This is very rigorous. They had 1 month, 3 months, 6 months, and then annual follow-up for these patients. And the follow-up duration in the study was at least 4 years. All of them had the BMI around 23, 24. They were all around a little less than 60 thereabouts, and many of them in the diabetic group had hypertension. They found at the end of follow-up, compared to prior to donation, 1 year after donation, at the end of follow-up, there was no difference in the eGFR in the donors, irrespective whether they were diabetics or non-diabetics. There was no difference in the albumin urea in the groups prior to donation, 1 year after donation, or at the end of 4+ odd year follow-up, or in the 24-hour urine protein before, 1 year after, and end of follow-up, suggesting that carefully selected donors could be eligible for donating. The 2021 paper was the last one, again from Japan, looking at feasible kidney donation with living marginal donation, including diabetes. They actually had all marginal donors, including age more than 70, blood pressures on antihypertensives, controlled blood pressures on antihypertensives, BMIs up to 32, HbA1c more than 6.2, less than 6.5, or with OHs. Of these patients, there were 12 patients who were diabetic in this with for 60-month follow-up. When they followed up a standard donor versus marginal donors who also had diabetes, they found that there was a lower EGFR in this group. But when they looked at only diabetic donors, the numbers that they studied did not indicate a difference in the EGFR in these groups. So if they suggesting again that if you choose donors with without any other marginal donor effect like hypertension, older age group, obesity, etc., it may be okay to take them. However, we need to remember the absence of evidence thus far is not evidence of absence. So, is it okay for donors to donate? Our for primary dictum is do no harm, and therefore I'm neither able to say a complete yes nor a complete no. It will be based on a very careful selection. I'd like to close by saying what our dysglycemia donor selection protocol is. We look at the diabetes risk score by looking at age, abdominal obesity, physical conversion, as Mohan et al. Has shown, is as described. So what we do is we then do an OGTT in these patients with high risk, and if they are okay, we proceed. Otherwise, if the risk is higher, we give them lifestyle advice. If the OGTT shows impaired isolated fasting glucose, and we clear only if the age is more than 50, or if the age of onset of diabetes in the donors is more than 35 and the IDEA score is less than 60. Similarly, we have got various criteria for isolated impaired glucose tolerance for various values, and those who've got higher values. And this is what we've been following. The results of this we'll know after 5 or 10 years, but as of now, this is what we follow. So to conclude, living donor transplant diabetic donors remains controversial. Usually, of course, it will not be a suggested donor. Could we accept in specific situation? That's what we have the discussion, but it has to be where we can do very, very close supervision. That is, the nephrologist takes the onus that we will supervise the patient, and the patient's risk has been explained, and the need for follow-up has also been explained. Thank you very much for your patient listening and for the invitation.
Excellent overview of the topic, sir. Sir, a question is, what kind of diabetes vintage would you be comfortable with? For example, 3 years, 5 years, or would you give that any importance?
So I can only tell you what the papers say. The 3 studies did not describe the duration of diabetes. The perspective article said of stable diabetes. That's what the perspective article said.
But if a patient comes to you with 5 or 7 years of diabetes, a stable diabetes to say, would you still consider?
So if you're putting me on the spot and saying, will I consider, the answer is no. But if you have nobody else to donate, and in a forum, in an ideal situation where you can guarantee the donors follow-up, I think the answer could be a yes. But I personally, I must say, I'm uncomfortable taking a diabetic donor.
And another one is whether history of gestational diabetes mellitus, would you consider that as one of the risk factors, because you didn't seem to mention it?
No, sorry, I hurried to the slide because I heard the alarm. If you look at the top column, I'm sorry, it's not projecting. The donors at high risk for developing diabetes has got diabetes in either parent, parental history unknown, but 1 or more siblings with diabetes, IDR score more than 60, history of gestational diabetes, BMI more than or equal to 25, PCOD, fasting glucose 100 to 125, postprandial 140 to 195, HbA1c 5.9 to 5.7 to 6.4. Any of these we would do a OGTT and then we would go. I'm sorry, I rushed through that part because I heard the alarm go.
Rushi? Yeah.
I think before I open the discussion to the audience,
Yeah,
the comments from our thing. So basically, doing all the 3 indications that we discussed today, the first was the easiest, where you have multiple vessels in a donor, because there the donor was not at any risk. So it was an easy ethical decision as far as taking that thing was concerned, as long as your surgical team was comfortable and sure and confident of getting you results on the operating table. The remaining 2, whether it was obesity or diabetes, both of them were quite ethically a big dilemma always as to which ones we should take, because somehow in practice, I find it very difficult to have any good donor follow-up. So unless you have institutes where you can enforce donor follow-up, doing these donors is always, ethically difficult, because I mean, they have come to you wanting to donate. So that part is clear that they wish to donate. Now, by allowing them to donate, are you doing anything wrong is the question that we are trying to answer here. And that I don't think can be laid to rest based on our current discussion, because there will be gray areas no matter how much we discuss. And unless you really have a very exhaustive donor follow-up program, I think it is best to avoid if possible. And if not, then in the current day and time, make sure you take a proper written video recorded consent. Make sure all the stakeholders are present in the discussion, because tomorrow this could come and bite you that you did not really take the informed consent. That's my take on it. And you should open it to the audience.
Yeah.
Yeah, Dr. Santosh, you discussed different studies showing the pros and cons of taking a diabetic patient. My question is, I think you answered that one already. What is the practice of CMC in this regard, number one? And you said doing GTT in this patient. If already patient diabetic, why you want to do GT? We used to do GTT in a relative of a patient who has, his diabetic patient. Donor is not diabetic, but we do GTT. But if patient diabetic, then what's the point of doing that?
So, sir, this thing was saying this is our dysglycemia protocol. We do not take diabetics. We just don't take diabetics. But the closest we have come to is assessment, so that we have a safe window of taking is for taking people with impaired glucose tolerance and assessing their risks and then choosing this is what we follow. But diabetics would not take, sir. So you're right. If somebody's already got diabetes, we wouldn't do GTT for them. We just would exclude them.
Ajay?
And I want to know how many people in the house are willing to take diabetic donors.
There are quite a few.
I think Dr. Sundar was traveling with me and he said in the last few years he's been taking. I think he just stepped out. He was saying about how he's taken and followed them up.
Dr. Sundar, don't worry.
So my point is more a comment to the House and to the Nephrology Society in general. I think we should try to move the country to where we get donors insured on their health and get them an health insurance that covers them for the next 10 or 20 years. And that would then ensure that we have actuarial data, because we would need to get companies to do it. And then we would also ensure that we restrict it to people who we have good evidence and data for as well. So I think for us, I would want to push the onus on us to try and get health insurance coverage for all donors that donate for us.
Aru? Yeah.
Okay. So we don't take it freely, obviously, because it is not
Kerala
permitted.
government has done that. Kerala government has done that. The recipient actually insures the donors the life.
Okay, I just have a comment here. So we don't do it because we are not permitted to do, but we would like to do, because one of the reasons is, as he has seen, there's a risk stratification there. Not everybody has the same risk. Now, if you consider the population now, 10% is diabetic. If you consider the population over 40, over 50, you'll be surprised. You'll find more than 30% is diabetic. You are excluding this same fraction, possible donors from the family, if you say that we are going to do donors. So I think this kind of protocols require to be made now. The risk is not the same for everyone.
I think we just have 1 or 2 minutes.
Hello.
Yeah.
Yeah. See, in Aurangabad, we have done 3 diabetic donors, and our urologist was very anxious what will happen medico-legally in case the problems are. So what did he suggest was that we get a kidney biopsy on the donor in a case where the diabetic retinopathy was not there. A coronary angiogram was done, which was negative for any significant coronary disease. And biopsy with EM was negative for diabetic retinopathy on the basement membrane level. So will that safeguard the diabetic donors to go ahead with?
I think that's what they showed in the pathology study when they looked at disease donors, and they found that there was the donors that were chosen were in general people who are healthy, who did not have significant diabetic nephropathy. But then we don't know the risk absence of nephropathy now and the future generation of the risk we don't know. So I think we have to choose older people if we do
Yeah,
choose.
old, yeah, they were all parents and 60+ people detected diabetes when the donor was evaluated.
May I request Dr. Srijit permission to close the session with his comments?
Yeah, one just not about selection, but one other thought I would like to bring is we have data, some data on diabetic from US as well as from Japanese. But my question is, should we be translating that data onto Indians? Because we know that diabetic phenotype is different types and our phenotype is different. The age of onset is earlier. Progression from impaired glucose tolerance to diabetes is much higher, 4-5 times compared to other ethnicity. So whatever safety data is available in Japanese or other ethnicity, should we be translating blindly to Indians? What do you think?
That's a very loaded question. The answer is obviously no. We shouldn't. We should be having our own data.
We should have our own.
I think it's not a very easy thing to say or to taking diabetic donors.
Yeah, the point I was trying to make is whatever safety data is probably not applicable to us. We should not be blindly accepting that. Thank you. With that, I think.
Yeah, thank
we'll
you
close
so
the
much,
session.
the faculty here today, Dr. Santosh and the chairpersons.